Welcome back, Dr. Butch. Today we're going to look at the Cardiometabolic Health Congress Part 3, and we're going to look at the evolution of obesity treatment. So I'm excited for you to jump right in with me on this topic. Are you ready?
Sounds perfect. Thanks.
Okay, excellent. So when we talk about obesity, one of the key things we often hear is that lifestyle modification is the foundation of therapy. Can you tell us a little bit more about what that means?
Yeah, I think that's sort of a double-edged sword, really. It makes sense to think that, on the surface, everybody should have a healthy lifestyle before sort of addressing their obesity. But that also it gives up, a certain bit of judgment saying that, well, everybody with obesity must have an unhealthy lifestyle, as if to say that nobody who, or people who are thin, who don't have obesity, have a healthy lifestyle. And these are just false comments and perceptions about the disease of obesity. Certainly, having a healthy lifestyle is one of all of our goals, regardless of our weight. And therefore, if we take that as the foundation and then build upon that of what interventions could we do, what therapies should we do that best helps this person lose weight and lead to a healthy weight range, I think that is sort of the foundation of where we start, and then obviously adding things to that. But I would push back a little bit about talking about foundations, because that brings up sort of this whole thing about, oh, it's a pyramid of treatment where you have to have sort of at the base level, you have to have lifestyle intervention, and only from there can you move on. We have to avoid getting stuck in this circle of death, meaning you're just continuing to work on lifestyle as if nitpicking on everybody's imperfections about their lifestyle. And I would say that we all have imperfections, and that certainly doesn't necessarily correlate with weight.
Yeah, I really like that, and you kind of moved into one of the next questions I wanted to ask you, but I'm gonna expand a little bit and look at kind of the challenges of lifestyle modifications. You touched on this a bit, but a lot of patients come in and they want to try more lifestyle, but maybe they've tried 60 different lifestyle modifications. So what are some of the challenges really with lifestyle modification as a singular focus?
Yeah, and I think you bring up a very important point, is that our patients probably already come with a history, and taking a history is important, like we've alluded in other sessions thus far. They've already come at it with trying. And we can say, well, you haven't tried hard enough, but that is the old way of thinking, as if to explain that obesity is a behavioral problem. But we know it's not that. We know it's a disease of dysfunction of energy regulation. So when it comes to talking about lifestyle, we have to figure out if, what lifestyle intervention might help that person. Now, if you take a good history and you talk about one's diet, one's physical activity, their sleep patterns, their sleep cycle called circadian rhythm, what stressors, intrinsic, extrinsic, looking at medication lists, seeing if there are medications that, maybe causing weight gain. If you address those as sort of the fundamental things you should address in an encounter, yes, maybe some of those things need work on, and you might work on those. But we should also accept the fact that if we work on those and someone does have a healthier, let's say, diet, for example, it may not affect their weight. And so we have to think very specifically about keeping maybe some of those two things separately. So if we're going to talk about a lifestyle intervention, let's specifically expect that it may not help the weight, but also in that case, avoid getting stuck, as I said earlier. If it's not helping the weight, let's move on. Let's think about another intervention, not to say that that intervention failed, or on the opposite side, be happy that something is successful, because I don't like using those terminology. I would rather you think that someone is either responding to that intervention or they're not responding. And that's why we have to sort of have some kind of guardrails to understand what a good response is. And we usually say around a 3-month period, if they've lost around 5%, then maybe they've responded to that intervention, whether it's a medication, whether it's a certain diet, exercise. But then the important thing, I think, Dr. Stanford, is if they're not achieving that, let's move on. And I think that's what we don't do a very good job of doing.
Yeah, absolutely. I think you touched on some really key points, and I like this language of responding versus not responding versus success or failure. I really think that's important, and I'm glad you introduced that. And so let's transition into really, one of the key things that I think, and this is that a lot of people are paying attention to things that do go beyond lifestyle, looking at anti-obesity medications. There's been a lot of excitement surround this type of medicine called this class of drugs called GLP-1s, these drugs like semaglutide and tirzepatide. And then of course, metabolic and bariatric surgery. But Dr. Butch, as we know, only 1% of individuals that meet criteria for medication actually get them, and only 2% that meet criteria for surgery get them. So let's talk about this evolution of treatment, what your thoughts are about the use of medications and surgical interventions, and any other thoughts you might have related to these more advanced treatments beyond just lifestyle modification.
Yeah, I think if we look historically, and that's where I'll sort of start it, is that if we believed at the time that obesity was a behavioral problem, it made sense to work on behavioral change. If that behavioral change model, which was steeped in bias and blaming the patient for their problem, if that didn't work, we then thought, well, let's give an appetite suppressant. So you see early on the development of drugs was to suppress this overeating problem of the, and I say that with sort of air quotes, this overeating problem of the individual, or this excessive hunger of the individual, almost to, say that the better suppressed, the more suppression of hunger would lead to more weight loss. And then that led to saying, okay, well, I'm going to not give this much drug. I'm going to give even more drug because that's going to be more suppression. Or if that doesn't work, I'm going to do surgery, because what does surgery do? Our thought at the time, makes someone have a small stomach. So they're forced, the behavioral change model, if that doesn't work and they're still having a bad behavior, well, let's, do a surgical intervention so they can't overeat, or they can't eat as much, or they have malabsorption of the food that they do eat. And all of this is steeped in bias, and all of this is steeped in a misunderstanding around the disease of obesity. Going forward, now that we understand about weight regulation and, all the things that we've talked about in the last couple sessions, we understand that we have to treat the patient with a specific intervention that may work. Lifestyle interventions we just talked about, but when it comes to drugs, we've went into the development that the hypothalamus, the brain is involved. Now we're understanding that there's connections between the gut and the brain. So the development of these drugs that seem to mimic some of the hormones that come out of our intestinal cells, like GLP-1 receptor agonists, GIP, PYY. These intestinal hormones have made up sort of this third generation of anti-obesity drugs. The second generation mainly were drugs that worked in the hypothalamus and were effective in some, but not, if you look at averages, weren't particularly effective across the board. But now all of a sudden, in the last year and a half, we have a tremendous interest in this third generation because of the efficacy of these drugs. And I think, fortunately, it's created a sense of understanding that obesity is a complex disease and the fact that it needs to be treated. We'll see what happens with that. But when we look at these drugs and we look at a surgical intervention, and you mentioned that, what of the low prevalence of using these, I think it's still steeped in the fact that we could go through a lifestyle intervention. We should, change someone's lifestyle before moving on, as if there's sort of a stepwise approach. But I think what we know now, if it's a complex disease, just like HIV, just like cancer, we're going to have not only monotherapy with drugs, we're going to have multiple drugs, multiple drugs at the same time. That's why we have combinations, or one after the other. And again, I think as clinicians, we've been sort of afraid to sort of go down that road, maybe due to a lack of knowledge or a little bit of bias, as we've talked about. But now I think with these drugs, people are getting more comfortable. And that's what I see in the primary care field, in the subspecialty outside of obesity medicine field. So it's very exciting to see that happen. But again, I think we have to figure out if there's responders or not responders. Some people can be on these very powerful medications, powerful in terms of their efficacy, and they may not lose weight. Not that they're doing something wrong, but maybe they're just not responding to that one pathway switch.
Right.
And we understand that very well. If chemotherapy is not working or radiation therapy is not working for someone's cancer, or if the first blood pressure medication isn't working, we don't sit there and say that, they're not eating, a low enough amount of salt. Again, we have to couch our understanding of obesity in the understanding that it's much like other chronic diseases.
Well, thanks, Dr. Butch. You've elucidated the complexity of this disease and the need for using other treatments beyond lifestyle for many individuals, and even recognizing with some of these more advanced therapies that not every single person is going to respond. And I really appreciate you talking about that and talking about something that a lot of people don't think about, which is combination therapy, like we do with any other chronic disease. So thanks, Dr.
Yes.
Butch, for being here. It's been a delight to have you with us.
It's been a pleasure talking to you today, Dr. Cody Stanford. Thank you.